Hi friends, for this week I have selected the topics in the clinical examination of the motor system. It's a part of neurophysiology and you know uh, it will be required when you are in the doing the CNS examination. So motor system examination. Basically, I'm going to take three parts: uh, tone, power, and coordination. These three aspects of the motor system, how to examine these three components, and what is the theoretical basis, and what happens in the disease process. First of all, when there is CNS examination done, it's required for the CNS cases like ischemic stroke, hemorrhagic stroke, resulting in hemiplegia, and so on. So, how to examine the motor system and what is the physiologic explanation to these examinations? Let's begin. I am going to discuss this in two parts. First, we will see the tone and power, and in the second part, in the second video, the coordination. Now, first of all, motor system means the voluntary motor activity. We perform voluntary motor activity on the basis of the functioning of our motor system. And first basic part that one must know, the theoretical aspect, is that the motor system functioning is governed by a two neuron path. There is a two neuron path that governs the functioning of the motor system. Since it's about the voluntary movements are first designed in our higher centers, the motor cortex, cerebellum, basal ganglia, and then these higher centers send the fibers down, the signals are sent down on the spinal cord, and from the spinal cord, the next set of fibers, they reach the muscle and the muscle contractions are made. So that is how we perform the voluntary movements. Now this is a two neuron path, as I mentioned, and I have made a very simplistic diagram for it. From the cortex to the spinal cord, it's called as upper motor neuron, and from the spinal cord to the muscle is the lower motor neuron. So motor system functioning is governed by the upper motor neuron and the lower motor neuron, a two neuron path. Now, basically, one must understand is that upper motor neuron has both types of influences on the lower motor neuron, excitatory as well as inhibitory, both types of influences. But inhibitory influences predominate. Remember this part. So, upper motor neuron predominantly exerts an inhibitory influence on the lower motor neuron. This should be always kept in mind. Predominantly, not exclusively, but predominantly exerts an inhibitory influence on the lower motor neuron. Now, just to have an analogy, if I stay with my family, I am the lower motor neuron and my parents are the upper motor neuron. Just to have the understanding, I am taking this as a simplistic analogy as to how this functioning happens and what happens in the lesion. I am the lower motor neuron and my parents will be the upper motor neuron. Now, upper motor neuron facilitate and as well as inhibit my activity, but inhibitory influences predominate. This is just for the sake of example. I repeat once again, this is just for the sake of understanding that both types of signals, but inhibitory signals predominate. Of course, parents are, they want to take care of their kids, and therefore sometimes they will allow certain things, but very often they will say, don't do this, don't eat that, it's not good for your health. So it's for our own good that the parents are inhibitory to us for a major part. So predominantly inhibitory influence uh, on the lower motor neuron. Now, what happens in the case of lesion? That is what I want to explain with the help of this. Now imagine you have come out of the house and start staying in the hostel, because now it's convenient. So you have come out of the influence of the upper motor neuron. Okay, you are staying in the hostel. What will happen? Your activity, my activity will be exaggerated, because now there is no more inhibitory influence of the upper motor neuron. That inhibitory influence is gone, and therefore there will be hyperactive lower motor neuron. My activities will be exaggerated. Uh, so that's the effect. Now, therefore, if the upper motor neuron influence is removed, what will happen? Excess activity in the lower motor neuron. So I am writing it here. Suppose there is a upper motor neuron lesion. As I mentioned, stroke or any lesion in the brain or this descending fibers, then lower motor neuron activity will be exaggerated, because that inhibitory influence is lost, and therefore it will be seen as increased tone, excess tone in the muscles, exaggerated tendon reflexes. So that will be the manifestation. Whereas if there is a lower motor neuron lesion, if I myself, the lower motor neuron, is not well, what will be the effect? Then my activity will be diminished, obviously. So in the case of lower motor neuron lesion, you must understand that, and I am repeating again, it's just an analogy to explain. Lower motor neuron lesion, see, lower motor neuron is the final common path that is reaching the muscle and sending the signal to the muscle. So in case of the lesion of the lower motor neuron, supposing upper motor neuron is intact, but lesion of lower motor neuron, then no signals reaching the muscle, and therefore what happens is there is decreased tone, loss of tone of the muscle, and tendon reflexes will be absent. So that's the result of diminished activity of the lower motor neuron, decreased activity, because it's the final path that is sending signals to the muscle. Now there is no signal to the muscle. This is what is the result in the lower motor neuron lesion. So that's how it happens in the remember, UMN lesion, the inhibitory influences are lost, and therefore lower motor neuron fires excessively. If there is a LMN lesion, then the activity is lost, activity diminished to the muscles. Now let us now see this. This was a theoretical basic information that you need clinically. Now let's see the examination of motor system with this background. Let's start with the first one, the tone in the muscles. As I mentioned previously, when we talk of motor system, we are talking about voluntary motor activity, which is designed in the higher centers and then executed by the muscle. So tone in the muscle, how do we check tone? First of all, what is the physiologic definition of tone? It is the resting tension in the muscle or partial amount of contraction that is still there in the muscle when the muscle is completely relaxed. Okay, that is called as the tone in the muscle. Even when the muscle is completely relaxed, there is some amount of contraction that is still there in the muscle, and that is called as tone. Now, how do we check this partial amount of contraction or tension that is still there in the muscle when it is completely relaxed? See, the patient is asked to relax the muscles completely, okay. Relax the muscles completely. Patient is not going to make any movement by those muscles. And then you will move the joint passively. The joint is moved passively. Now, when you move, let's say, elbow joint, biceps and triceps tone is being examined. So, place your hands on both biceps and triceps, and then patient is relaxed completely, not making the contractions actively, and then you will move the joint passively, flexion, extension, flexion, extension. You will feel the resistance encountered during this movement. Whatever little resistance encountered when you move the joint passively for the patient, that is called as tone in the muscle. So, clinical definition of the tone is resistance encountered when the joint is moved passively. Now, when you flex the joint, which muscle's tone you are checking? It will be the triceps, not biceps, because it's the partial amount of contraction which is still there in the triceps, which is opposing this movement of flexion. Okay, triceps is the antagonist muscle for flexion. So that triceps contraction, partial amount of contraction, is opposing this movement, and therefore you feel that resistance. And therefore, to avoid, so remember, when you are flexing the joint, actually you are checking the muscle tone or partial contraction of the triceps, even when it is completely relaxed. So, to avoid the confusion, what you do is place your hands on both agonist and antagonist, and then make the movement, both movements simultaneously, flexion, extension, flexion, extension. So, passively moved, and now whatever resistance you felt, accordingly you will say the talk about the tone. Basically, why there is partial amount of tension in the muscle? It's said to be because of the asynchronous gamma motor neuron discharge. Asynchronous gamma motor neuron discharge. Gamma motor neuron from spinal cord to the muscle maintains the excitability of the muscle spindle, which is the receptor in the muscle. And then the muscle spindle, the receptor, proprioceptor, it sends the signals back to the spinal cord and causes activity in the alpha motor neuron, and that alpha motor neuron causes slight contraction of the muscle. Remember, the muscle tone is different in different muscle groups, but it is more seen in the extensor muscles. In the extensor muscles, anti-gravity muscles or postural muscles, the tone will be little higher compared to other muscle groups. So, that's about the tone. Now, in the case of upper motor neuron lesion, there will be excess tone in the muscles. As I have already mentioned, upper motor neuron lesion. So, excessive tone in the muscles. Now, how will you feel that? There will be lot of resistance to the movement. So, that's the tone is increased, excessive tone. It can be called as spasticity in the case of pyramidal lesions, or rigidity in the case of extrapyramidal lesions. So, these are the terms used for hypertonias. In the case of lower motor neuron lesion, since now there is no signal reaching the muscle, there will be loss of tone. So, it is called as hypotonia, and hypotonia generally also sometimes referred to as flaccidity. So, you see, there can be a spastic paralysis, or then there can be a flaccid paralysis of the muscle. So, spasticity, hypertonia, flaccidity, hypotonia, loss of tone or decreased tone. That was about tone in the muscles. But the point that I wanted to make was definitions of the tone. Physiological definition is partial amount of tension that is still there in the muscle when the muscle is completely relaxed. And as I mentioned, there is tension in the triceps, partial amount of tension in the triceps, and it is opposing the flexion. Therefore, when you are flexing the joint passively, in the patient, you are actually checking the tone of the triceps, because triceps is opposing that movement and tone in the triceps is causing that resistance felt when the joint is moved passively. Right, but to avoid confusion, as I mentioned, place your hands simultaneously on agonist and antagonist both and make both movements simultaneously. Check for the resistance offered, resistance encountered, and that's how you check the tone. So that was clinical examination of the tone. Next is power in the muscles. How do you check the power in the muscles? Well, there are two ways. Now here, first of all, I am assuming that in a normal person there is grade 4 or grade 5 power. Grade 5 is seen in the normal individuals. And how do you check that power? Assuming, I say assuming that the person is normal, apply resistance to a movement. Suppose I am checking the power in the biceps. I will ask the patient to perform that action of the biceps, flexion, and I will resist it. Now see, this time patient is contracting the muscle actively, okay. We are checking the power in the muscle. In the case of tone, there was just a passive movement of the joints. Now, power by either this way, that you apply the resistance. Suppose you are checking the biceps and its power in the patient. Ask the patient to perform the action of biceps, flexion, and you apply the resistance. Okay, just I am adding one more point relevant here. Whenever you are performing the CNS examination, always remember there are two halves of the body and there are two cerebral cortices, I mean two hemispheres. And as you are aware, right hemisphere controls the left half of the body and left hemisphere controls right half. So always remember to check on both sides. Once you have checked on one muscle, then you can check on the other side as well. So that should not be forgotten, just an additional point. Now, power, either check like this, you apply the resistance and ask the subject to perform this flexion. So you are checking the power in the biceps. Or there is other way also. Let the patient perform the movement entirely. Biceps causes flexion entirely, and then you try to undo that movement, undo that complete flexion at the elbow. So a patient is asked to maintain that flexion and you try to undo that position, okay. Patient is actively contracting the muscles at this time and you are checking the power in the muscles. Now, the point that I wanted to make here is slightly different from this. There are grades of power. Very often this question is asked during clinical examination. What are the grades of power and why do you need to know the grades of power? So let's try to understand this. Suppose, okay, first of all, there are 5 grades of power. Now suppose a patient comes and there was a hemorrhagic stroke very recently, let's say about 1 or 2 days ago. You will check the patient, his motor system and power is being checked. Grade 0 means no contractions visible whatsoever. You ask the patient to contract certain muscle, no contraction seen. Grade 0 power. Grade 1, a flicker of contraction seen, means you ask the patient to perform some movement, contract some muscle. You can just see that the muscle is flickering. I mean, there is some contraction, some attempt being made to contract the muscle. So a flicker of contraction can be seen there. But actually, joint is not moving. There is no movement possible. That was grade 1. Grade 2, movement possible now. Movement of the joint possible with gravity being eliminated. If the gravity is eliminated, then the movement is possible. So there is some strength, some power in the muscle. So if you just ask the patient to place the limb like this, and gravity is eliminated and there is the limb is well supported, then the patient can move the arm, move the limb like this. Gravity eliminated and just some amount of contraction, some power is there in the muscle. Grade 3, contraction possible against gravity, movement possible against gravity. That will be the grade 3. So if you ask the patient to lift his arm, then arm can be lifted against gravity. That's grade 3 power. Grade 4, contraction against slight resistance. Contraction possible against gravity, it's there already, and contraction against slight resistance offered by you. You apply slight resistance, small amount of resistance to the muscle, and movement was still possible. That's grade 4. And grade 5 is the normal power, that is contraction possible against maximum resistance applied by you. So that will be the normal power. Now, why do you have to know the grades of power? Obviously, the reason is when the patient came and he or she had a recent attack of hemorrhagic stroke, the patient will present with grade 0 power. But then with your treatment, with the physiotherapy and other aspects of treatment, subsequently the power is going to increase, right? It won't go from grade 0 to grade 5, or it won't become normal. It will go through these grades. Step by step the power might return, and when the power returns, you can see the grades, and accordingly you can make the inference that okay, it's improving. So that's one reason why you have to know these grades of power. Step by step return of power is can be seen, and therefore these are the grades of power, and that's why you have to know the grades of power. Right. So that was tone and power.